Hello, everyone, and welcome. Thank you for being with us today. We are broadcasting live from New York City, where our guests are. And as usual, I'm in Park City, Utah. So welcome. Thank you for being here, everybody. We have a super fortunate to have our guests with us today and a topic that because you're here, you're probably keenly aware of, and not perhaps personally, but the challenges that go along with IVF and that sort of thing. And we were just having a quick conversation, and obviously I've done some background on this, but aside from being able to arrange things so you can procreate when things are seemingly stacked against you, there's a really interesting business opportunity embedded in all that. So, Marco, you came back on through the presenter log, so it's okay, no problem. So we've got a bunch of folks coming on today. I welcome all your questions. Please be sure to put them as they come to mind in the chat box in the Q&A. And also, as usual, we're going to be recording this, and we have permission to post it to the Family Office Insights YouTube channel, but we'll also be sending the file off so our guests can post it in a place where you can find out more information. And also, as usual, if they're after hearing what you hear today, if there are others in your world, in your community, friends, family, that sort of thing that would be interested in hearing about it, you're welcome to shoot them the link to the recording, and we're going to put you direct contact with David, Marco, and Abigail here. Abigail, I didn't mean to put you at the end there. You should be in the front. So with that, please, again, if you have questions, post them as soon as they come to mind so we get a chance to get to them. And don't hesitate to do so in the chat box or the Q&A. So welcome, everybody. Thank you for being here. David, thanks for being here today. Welcome.
Thank you. Thank you, Arthur. I appreciate the forum. Thank you to everyone who's tuning in now and maybe listening to us later. I want to introduce myself briefly and then have Abigail Cyrus, my associate, introduce herself. And we'll briefly walk through just what we see as our little area of healthcare, our area of the healthcare economy, and mainly the problem that we're trying to solve and the way we approach it. My name's David Sable. I'm an MD by training. I was trained in obstetrics and gynecology, then reproductive endocrinology at UPenn, Cornell, and Brigham and Women's Hospital in Boston. I co-founded or founded 2 IVF programs, in vitro fertilization programs, as well as a reproductive genetics company years ago. About 20 years ago, I took a 1-year sabbatical from medicine because my children did not know who their dad was. So I was never home. That 1-year sabbatical is now in its 20th year. Most of that time has been involved in healthcare investing. And over the past 10 years, a big portion of that has been going back to my old field and trying to re-engineer in vitro fertilization. But I let my associate, Abigail Cyrus, introduce herself, and then we'll get into the story. Abigail.
Thank you, David. My name's Abigail Cyrus. I support all of our investment decisions as an associate, and I joined the firm about a year ago, although I've known David for a couple of years. In my previous role, I was at IBM in tech consulting and minority equity investing in quantum computing. And I had the pleasure of working with David and a number of other stakeholders across the reproductive medicine industry on a project for IVF, which is where we first got introduced. I'm actually the product of in vitro fertilization myself. My twin brother and I would not be here without it, so it's a cause that's very close to my heart. And it's a joy to get to work on this industry and to help our founders innovate in the ways that they do so that we can improve access for as many people as we can. So it's a pleasure to be here with you all today.
Nice. Thank you both.
Thank you.
David, let's hear how this came about.
Well, I'm a doctor and I'm an investor. And this is a story that I always try to tell from the mind, and I always end up telling it from the heart, because it becomes pretty evident when you start working with people having difficulty having a family, that this is not a consumer discretionary part of the economy. This is really a foundation of people's lives, and the impact that we can have on people's lives is extremely important. What surprised me when I transitioned out of practicing medicine to studying healthcare and investing in it is just the extent to which we're not helping people with in vitro fertilization. Now, IVF was invented 40 plus years ago. And over the years, we've created almost 10 million babies in 40 years. And every one of those babies is a miracle. Every one of them, and Abigail's a good example, has been a blessing to their families, just invaluable and incalculable. But when we study the industry, we really should be making or helping create 1 million babies a month. And when I modeled out the sheer need for this procedure, for its traditional use in helping people with chronic infertility, for people that have repetitive miscarriages, and for other uses where it's extremely helpful, things like preventing genetic disease like sickle cell anemia or cystic fibrosis, the use that it's extremely valuable for, we find that we're treating maybe 1 of 40 people worldwide that need it. Interestingly, of the developed countries, the United States has the lowest access of any of the economies that we studied. And when we looked for cause and effect, why, when we have this terrific procedure that we've been making better and better over 40 years, what's keeping people from it? Well, there are 2 reasons. One is most economies, it's too expensive. The price tag is very high, and there's little insurance coverage. Secondly, geographic access. Most people live far away from an IVF program. So we have millions of people who need it. Worldwide, I modeled out 25 to 28 million babies per year. Babies that the world really wants. This is an important foundation for our future, are not being born that with access to IVF could be. That 25 to 28 million babies would equate to about 50 million to 60 million IVF cycles at a minimum. What are we doing? We're doing about 2.5 million worldwide, and we're helping about 500,000 babies per year be born. So we try to define what we do not by what we're doing in the day or who we're seeing. We try to see what problem are we solving. So the problem that we want to unlock is access to in vitro fertilization. We want to make IVF as available as dentistry. We want to, moving away from healthcare, we want to make it as easy to do an IVF cycle and have a baby if needed as it is to own a cell phone or a personal computer. When we study the IVF industry, we found that the best correlations weren't with healthcare, but they were with technology. IVF right now is where airplanes were when the first jet was invented. 40 years after the first plane was invented, the first jet was invented. Almost nobody had access to air travel. Now everyone does. I bought my first computer in 1988, about 40 years after the first computer was invented. That computer sat on a desk, didn't talk to any other computers, cost about $4,000. And it was a terrific piece of technology for 1988. I couldn't foresee what computers were going to do from then on in. Now, I was fortunate to be able to practice IVF for 20 years. I did thousands and thousands of cycles. I still get baby pictures from my old patients. Mm-hmm. Some of those babies are now in their 20s and 30s.
Nice.
And it's a great thing to have done. But the better the procedure got, the more glaring the fact that most people that needed it weren't getting it became. Now, I'm under no delusions that we were going to wave a magic wand and out of the goodwill of the world, make IVF available. I do have a degree in accounting, a degree in economics. And I know that You can no more ignore the rules of economics, but you can ignore the rules of gravity. So I set about asking myself, what's keeping this industry from growing? What's keeping it from growing organically? We've got this enormous demand for this procedure on one hand. And I treated patients with infertility for years, and they would do anything if it would help them start a family. And we kind of, brought those values in ourselves. Everyone from the people that cleaned the office to the doctors and the scientists that did the procedure. This is what got us out of bed, got us to work every day. So you've got this enormous number of people with the most noble, important goal. We had a really great procedure that was getting better and better every year, but yet we didn't have a marketplace that was expanding to match it. So we set out to solve that problem. And the goals were several. Goal number one, anybody that needs IVF can get IVF. Goal number two, the best practices now, the best probability of having a baby should be our floor for the quality of the service that's being offered. And number three, we have to engineer it so that we can get certainty to it, so that nobody has to mortgage their house and pay $10 or $20 or $25,000 for a cycle and have nothing to show for it. So to us, we wanted to build the right kind of marketplace. Now to do that, and I'm going to get to, I'm going to ask for everyone's indulgence. I'm going to pull a couple of slides out. This is a story best told with words, but there's a couple of pictures I want to show.
Yeah, pull them up.
And, nope, that's not it. First thing we did is we mapped out the patient journey in IVF. Upper left here is the patient herself, and the purpose here is not to read what's in every box, but just to show the complexity of what the patient goes through as she works on her own. And she may work with her OBGYN, and then interacts with an in vitro fertilization clinic and in vitro fertilization lab. And each one of these boxes is an interaction, patient to patient, patient to doctor, patient to laboratory, doctor to laboratory, or one laboratory to another. And each one of those interactions is a business. And each one of those businesses is either done well or it's being done poorly. It's either priced in a way that can be affordable by everyone, or it's priced in such a way that keeps people locked down. We took each one of these boxes, each one of these tasks, and we ranked them. Said, all right, what's working and what's not in this environment? We took that analysis and we mapped it. We found four major problems with the way this economy, the way this ecosystem evolved. One was we were misusing our medical labor.
David, we are still seeing the patient journey. I'm not certain if you're on the other slide yet.
Did new boxes get added here or no?
Let me see what I can do here. So this is the patient journey.
Yeah.
I'm going to stop sharing for a second.
Yeah, probably.
I'm sorry.
It's a little tricky sometimes.
You figure we get Zoom figured out by now.
Yeah.
Okay, that's one. Looks like I'm frozen on that. Excuse me. See if I can get to the second. No, it's showing me the wrong one too. Well, to go back to the narrative, we took each one of those interactions that the patients, the doctors, the laboratory technicians, the scientists had. We figured out what's working, what's not. We mapped them in a way that if we could come up with solutions for each one of them, which one of those solutions would make the procedure work better, would make it more accessible, and make it cheaper. Now, we put our business people's hat on. This is a discipline that Abigail brought to us. We came up with 3 KPIs, 3 key performance indicators. Dollars to baby, time to having a baby, and life disruption. to having a baby. The things that I noticed over the 20 years of practicing were the same things that my patients were trying to figure out when they're trying to decide to allocate money and time and emotional energy to going through IVF. And we've been on a 5-year journey now, meeting every company that we could, every founder, every incumbent, every payer, every potential acquirer. And we put what they did through that filter. How valuable are they within the ecosystem, or what kind of roadblock are they in the ecosystem? Out of that came our shopping list, the things that we thought on a venture capital level, at a private equity level, that we could invest in to open up this marketplace from the half a million babies we're creating now, helping 2.5 million treating 2.5 million families, to the 25 million babies that we want to help the world bring in, treating maybe twice that number, 50 million people. Now, taking a step back and taking my doctor and humanitarian hat off for a moment, we did recognize that we're not going to make this happen unless we made it a good business. So we modeled out the industry itself. Right now, worldwide, the IVF industry is about a $25 billion revenue industry, which is about the revenue of the Heineken beer company. Now, I've got nothing against beer. Actually, I happen to be a fan of Heineken's beer. I think that if we look at what it is that we're solving, what it is that we're trying to help the world do, and then we ask ourselves, is there really a desire to spend this much money or that much more for this? That answer was pretty easy. So we went back and modeled the total addressable market. We said if we take all the families that suffer from infertility in a year, and we modeled that out to about 12 to 13 million families worldwide, and I'd be more than happy to provide references, go through my 120 slide deck to provide the data behind all of this. We have 12 to 13 million families suffering from infertility. We have another 7 million suffering from habitual miscarriage. These are families that get pregnant over and over again, and the pregnancies are lost somewhere usually in the first or second trimester prior to being viable. And in many ways, that is as much or more suffering than infertility. Then if we applied IVF to families that are at risk for having diseases, genetic diseases for their children that result in childhood death, sickle cell anemia, cystic fibrosis, spinal muscular atrophy, some of the hemophilias. And then we applied IVF to the members of our families that are in the LGBTQ community, as well as trying to model out people that have had cancer with life-saving treatment, but unfortunately the treatment left them sterile.
Yeah.
That gets us about to 25 million babies per year. Then let's make an assumption. Let's assume that we can treat everyone and get them pregnant with one IVF cycle. And rather than the $45,000 to $60,000 that it costs to have a baby through IVF using repetitive cycles, let's assume we can have them get pregnant with $12,000 to $14,000 per outcome, not per cycle, per outcome, only paying if the cycle succeeds. And we add all that up, we model that out to well under over $400 billion per year. A 16 to 20-fold increase the amount of economics that the industry is generating right now. So from a business standpoint, I went back and I tried to find another area within healthcare that had that potential for growth purely from a business sense. Putting aside the relieving of suffering, the diminishing of pain, taking that all aside and say, let's just purely put my grubby venture capital hat on only. How much money can this generate as an investment vehicle? And we're looking at a 16 to 20x expansion of the economy. That helped us convince, took us from let's study this to let's do it. And that's the story, really the story about that brought us to where we are. We started investing in the field about 3 years ago. We started picking from that shopping list, trying to meet the most talented innovators that we could. And our job is to support this industry and help grow it. And I'm going to leave it there for now as an overview and take a break for some questions if we could.
Super evocative. Thank you. What is for those of us that don't know, the continuum between getting success in the first try and 4 or 5 tries later? Is the technology such that there's a skill gap with the physician that can be rectified, or is it the type of process or procedure? I mean, what's that look like?
That is a great question, Arthur. To put a little historical context in it, when I started doing IVF in the early 1990s, the pregnancy rates were absolutely dismal. High single digits to low teens per cycle. And each cycle, we were putting back 2, 3, 4, or 5 fertilized eggs called embryos at a time. So that not only the chance of getting pregnant was very low, but if you did get pregnant, your chance of getting pregnant with triplets or more, which is replacing one medical problem with another one, was very, very high. So our batting average was lousy, and it was bad everywhere. Now, starting in the early 1990s, we really started teasing out the science. And we started making one thing after another work better. By the late 1990s, we had clinics that had pregnancy rates in the upper 30s to low 40s. We were putting back 2 or 3 embryos at a time. And the procedure was getting better, still not as good as it could be, still much more science than it was engineering, but we were heading in the right direction. Fast forward to now. We now, in most cases in Western Europe and the United States, we put back 1 embryo at a time. The probability in aggregate of having a baby is about 1 out of 3. Far, far from where we were 10 and 20 years ago. The problem we face is that the spread from one laboratory to the next is way too broad.
What's that mean, spread?
The
You mean
spread,
the success gap?
exactly.
Yeah.
The best clinics have a probability of over 60% putting back 1 embryo in 1 cycle. So the way an IVF cycle works is you usually take fertility drugs for a couple of weeks. We put a bunch of eggs into the laboratory, we fertilize them all, and we take the best, we wait a few days, see how they develop, take 1 or 2 and put them back. Then we can freeze the rest, or freeze a number of the further ones, so that the number of times you need to take the fertility drugs is minimized. So the goal is we can get the best probability, get the probability of putting back 1 at a time to 80, 90%. And the scientists that I've spoken to and the work we've done indicates that we should be able to get there, somewhere at 80, 90%. Then the number of times you need to take fertility drugs goes down to 1 instead of every month. And we engineer it to where we can figure out what's working in the clinics with the high rates and replicate it and automate it so that we can do this, we can do best practices everywhere. So our goal is to keep getting the pregnancy rates higher, but at the same time, match the quality of the science, which is outstanding. This is world-breaking science, 1 Nobel Prize so far, probably a few more to come. But frankly, the engineering has been lousy. Every IVF lab is kind of like its own boutique kitchen with their own recipes, their own way of doing things, their own way of measuring, their own way of doing quality control and quality management. So our job in the 21st century is to engineer the process so that we can standardize it around best practices. A big part of our strategy is to take the human-produced procedures that are very operator dependent, to find a best practice and automate them if we can. Figure out what we need to measure it, and keep making the process better. It's ironic that we're trying to take a 21st century technology like IVF, and the group that we really want to borrow from is Toyota's assembly line. We want to engineer it to the type of certainty that we get in other things. Now, once we get that certainty out there, suddenly the insurers are more than happy to jump in and insure it. When we automate it, then we take away the bottleneck of having a tiny number of specialists holding all the secrets. We take away the need for really advanced scientific skills because we just borrow things from cell biology, things that are working in the pharmaceutical industry, that are working in the energy industry. Extremely well-engineered systems, we put them to work for us. Put all that together, we're talking about a synergy, a growth, a scaling of the industry in a way that takes us to that one cycle, one baby, affordable for everybody, available to everybody. And no one pays, nobody has to mortgage their house or ruin their economics in a way that doesn't result in them getting what they came to the process for. Very long-winded answer to your question.
No, it's a good, it's super important to explain it that way. I think because it helps us who aren't in the thick of it, like you, for example. I'm not sure this applies, but would you say that, and this is going to sound disparaging to the academia, but it really isn't. It's just incumbent thinking or process, that sort of thing. So academia has suffered from the siloing of information and process and procedures, whatever make up the list that you want, by the method for which they get funded. And so oftentimes we see funding for research and the resulting paper, I'm oversimplifying this, that allows for the funding for the next research grant to be siloed and not shared with the world, because that's how they get funded for the next project. So if they did the Google thing and shared it with everybody, then it ruins their economics because that's the way it works, right? And so you see some of that getting resolved. Do you think that that's one of your challenges, is to get the, if I want to have a baby and I know you're the best doctor, I'm going to pay you whatever you need to get paid, just to be very direct, and you might have a secret process that you're not sharing with anybody else. Do you see that silo of process and methodology a challenge to democratize?
Yeah, it's a great question. And it has slowed things down a bit over the past 40 years. I think that the progress we've made has been remarkable. I do know that there are certain things that we learn that we keep to ourselves for a little while. That said, the biggest advances that we've seen have mainly, and this is kind of ironic, IVF doesn't get funded very well from academics. There's almost no NIH funding. The joke in our labs has always been, I can get a grant for examining sperm in a dish. I can get a grant for examining an egg in a dish. But if I put the egg and the sperm together, forget it.
Pretty funny.
It'll never happen. So most of the innovation that we've seen in the science and in the in the engineering has come from private laboratories. The nature of those laboratories trying to grow has been that things would get taught. Most of these were processes and procedures and not individual molecules and things of that sort that could be patented. So that there has been a decent amount of spread within the industry. For example, in 1992, we invented a procedure called ICSI, which involved just manually taking a sperm cell and placing it inside the egg, which in 1992 was mind-blowing. We never touched the egg. The egg was, we were afraid to touch the egg because we thought the egg wouldn't be able to grow after that.
Mm.
And we developed the ability to place the sperm into the egg, and enormous populations of severe male factor infertility that for the first 2 decades, IVF didn't work at all. Suddenly it became a routine procedure. Within a year, every IVF lab in the world was able to do it.
So the problem was that the weak sperm couldn't penetrate the egg, and that's a different set of problems as opposed to the strong sperm being able to penetrate. So there's a whole cohort of people whose sperm couldn't swim fast enough or whatever, right?
They
I
couldn't
don't mean to
swim.
oversimplify it, but
No, it's actually a very good description of it.
Yeah.
Or the number of sperm was just so low
so low.
that you need a critical mass around the egg for one to make it in. So we were able to jump in and take care of this very, very quickly. That said, all the work that's been done out of these clinics, most of which was funded by the clinics themselves, mainly it was science. It was, how do we make our own process better? And then by and large, people have been very good about sharing it with others. Part of it was that it was one thing to know how to do it. It was another to develop the talent to do it.
Yeah.
These were manual procedures done by sort of, just like craftsmen. The work being done by the embryologists underneath an operative microscope is remarkable.
Just can't imagine. Yeah.
The work that we haven't done, which we want to focus on, and what our research has shown, is the engineering part of it. The defining what needs to be measured, what needs to be optimized, what can be standardized, and what can be automated. How do we take that spread? In the United States, the average cycle of IVF is about a 1 out of 3 chance of turning into a baby. Worldwide, it's about 1 out of 4. How do we bring all that up to that 60% that the best practitioners are doing now? The fact that we can do it, and these are some of the most successful programs in the country. It's not like they're treating a tiny number of people. The fact that we can do it tells us that we can do it with everybody.
Yeah, that you can engineer it. Exactly. That makes sense to me.
And it's an engineering problem, which thankfully, engineering risk is much more modelable and lower than science risk.
Yeah, for sure.
When we circle back to the investment case for this, it's not like we're inventing a new molecule, putting it into the human body for the first time in history and hoping for the best. It's a matter of, we're going back to the Toyota assembly line. How do we just process, optimize it, and engineer it so that we can scale the industry, bring it to more people, and grow from 25 billion to close to $500 billion in terms of business?
So for the group, I think I mentioned this, at least in a communication, perhaps not at the beginning of this chat, but we are going to get knee deep into the investment opportunity in a few days with another webinar. But can we talk a little bit about how that's going, wrangling the engineering part of it that can be engineered?
Sure, it's going quite well. Part of it is first basic principles. One of the issues we run into in fertility, as well as women's health in general, is that there's not a lot of things that we know how to measure. It's shifting emphasis for a moment, as an example, look at oncology, look at cancer.
Yeah.
We unlocked the human genome 20 plus years ago. So we had a Rosetta Stone to look at the genetics of cancer. It's an enormous new vocabulary, a whole new world that we had to study. On top of that, we have the ability in cancer to take a piece of a tumor, put it in a dish, and do stuff to it. Experiment, sequence it, look for things that make it grow, things that make it stop growing, to really understand it. In other words, to engineer it, to accrue data. There's other areas of medicine where we just don't have that. Neurology is one. The slow development of understanding of Alzheimer's disease. It's because we really can't do brain biopsies serially. There's not only so many things we can measure and observe. And in women's health, the whole reproductive system is closed. A pregnancy or an embryo, once it goes into the womb, doesn't give us much information until weeks later, when we can start measuring hormones and doing ultrasounds. So what's happening in the meantime? So the first thing we need to do was define the stuff that we couldn't measure and try to figure out how we could measure it. This is where this particular decade is very, very exciting for that type of thing. Because we have new tools, and everyone's heard the terms artificial intelligence and machine learning, which, depending on who you're talking to, can mean something different to everybody.
Mhm.
But to us, artificial intelligence and as an application of machine learning means that we can hone different systems to look at our processes in ways that we're not smart enough as humans.
Mhm. And speed,
So,
right?
Processing it, look at
Yeah.
things differently, higher speed, look at them in much higher volume. Like if you put a semen sample under the microscope and I look at it as a doctor, I may be able to track 10 or 15 of the thousands of sperm there. Try to find something that's good enough, isolate it, pick it up in a test tube, and use it to insert into an egg. If we take a machine learning and we take a lens from the Defense Department or from meteorology, something that's used to looking at cloud patterns or crowds or movements of, from hundreds of thousands of miles away, look at what's happening to different air pressure readings. And we take that same methodology, say, look at this embryo, watch this embryo as it develops for 3 days. We're going to be able to do things like extrapolate genetics of that embryo from it. We're going to train that same system on a dish with thousands of sperm and tell the visualization system connected to a computer, choose the single best sperm from this.
Hmm.
And we already have ways that the computer can tell us, can talk to a probe, tell that probe to immobilize that sperm, and then pick it up and use that to insert into the egg. And we're working towards doing that with a human not even touching it.
Fascinating.
So the embryologist, the scientist that's terrific at doing that at 8 o'clock in the morning, after 8 hours of sleep, a cup of coffee, and a good breakfast, that same embryologist getting a little tired by noon, and by 2 o'clock in the afternoon, forget it.
Mhm.
We can have a machine do this 24 hours a day, not only with no drop off in quality, but continually learning from itself so that the process continues to improve. Now, what I just described is maybe one of dozens of processes that we can put into this engineering process and continually improve. And that's going to take us from 1 or 2 labs being able to have a 60% pregnancy rate or a 65% pregnancy rate to every lab having an 85% pregnancy rate per embryo that goes back. It can take us from the doctors overseeing 250 cycles a year to overseeing 5,000 cycles a year.
Hmm.
And the embryologists, the scientists who are doing all this manual work, we can move them into a quality control, quality management role and have them also overseeing tens of thousands of cycles. Scaling up, taking the bottlenecks, breaking them away, and making a higher probability of having a baby each time available to more and more people for less and less money. But in aggregate, a very, very large business opportunity.
Yeah, and
Well,
probably,
that would be a great thing to do.
yeah, that would be a great thing to do. I mean, yeah, I'm just an investor, so I think about things that can go wrong, right? So, is the incumbent thinking of doctors that want to keep their hands around the cookies of being able to do 60% and not, I mean, you could articulate the business less time, more money, same time, more money, then reasonably intelligent people can understand that. But is there sort of a, I want to keep my hand around my cookies and I don't want everybody else to be able to do 60%?
There's an element of that.
Yeah.
Thankfully, no one person holds the secret to unlocking this, but we tackled that attitude in our strategy, and our feeling is we can do this with the incumbents or without them. We can do this with the most highly trained specialists, or we can do it without them.
Yeah. I can
Similarly,
see.
we can do it with insurance or without it.
Yeah.
Since it's an engineering challenge and not a science challenge, we figured there's really no reason with unlimited processing power, extremely cheap energy, cheap storage and memory, and a fairly standardized playbook for IVF that we can't bring everybody up to the highest possible level. It'll take a little bit of time. Again, some of the things we need to figure out. There's things that some of these laboratories are doing that even if we gave them truth serum and said, okay, what's really the secret here? And I've been in one of those labs. I've ran one of those labs. I would honestly say there's some parts of it we just don't know.
Don't know. Yeah.
But by improving our ability to measure, to observe, and to collect data, we're able to knock this complex series of interventions between the patient and then the sperm and the eggs and the embryo, break it into its component parts, and figure out, okay, what's not working? What are the things that we're not looking at that we should really be paying attention to and adjusting that are going to give us this big quantum leap up from the average lab to the best lab? And at the same time, tell that best lab, it turns out that you were doing this. And that's
replicate it. Yeah.
too.
Yeah.
And once we do that, then we can grow from there. I'm not satisfied with the 65% pregnancy rate. The number we have to aim at is 100. Now, nature doesn't like 100%.
No.
But we get to 85, 90%, and then we're able to open up a marketplace where that 25 million people that need to have a baby or a healthy baby, avoid a disease, it's available to everybody.
Can we talk a little bit about why you're not just some doctor that decided to be in the investment business? And for this particular thing, that it's been quite some time that you've been actively investing, and why you're probably a good person to tackle this problem. How about that for setting you all up?
Arthur, that's kind of you to say. And I'm more than happy to be considered just some doctor who wants to do this. But I do. First of all, I don't like talking about myself, so this will be a little uncomfortable.
Well, give us a little bit anyway.
I do speak the medicine. I speak the healthcare, and in order to speak the medicine well, you need to speak the science. The basic science. Medicine is like math. Math and physics. What math and physics are to economics and engineering, biology is to healthcare. And I was blessed. I worked with absolutely the best scientists that did IVF from the beginning. The director of my laboratory came out of Steptoe and Edwards' lab, the first IVF baby. We go back to the beginning.
Wow.
So if we're going to unlock this, the same way we unlock an assembly line that creates automobiles or computers, we have to know physics. We have to know our math has to be as good as it can be, and our ability to manipulate and gather data has to be 21st century, and that's the way we approach that. Similarly, I do think that there are not too many people that have worked in the industry, gotten their hands dirty, been on the shop floor for several decades, that then stepped back and studied the IVF industry as an industry. We've mapped the industry from the founder level through the proof of concept of new technologies, through commercialization and marketing to the bigger companies that do the acquisitions. We've mapped how funding works in IVF. We see $20 of private equity for every dollar of venture capital in IVF. Well, why is that? Why this stratification of risk? Why this triaging of capital to the consolidation of the existing profitable part of the industry, while we're ignoring the building blocks for building the much larger industry that we want to grow alongside it? Now, there are a lot of people much smarter than me, better than what they do, than what I do, that I can have the conversation about funding, that I can have the conversation about managing a scaled IVF program that, instead of doing 1,000 IVF cycles and creating 400 babies per year, is going to oversee 100,000 cycles a year, creating 60,000 babies. And there are people that understand what happens in the laboratory a lot better than I do. The doctor part, that's good. But it's really, to me, it's the ability to converse, to be that grand central station for innovation in IVF. And what I didn't know, which was a lot, the areas that I really needed beefing up, I said, well, how do I scale myself? I spent a year trying to find Abigail Cyrus. Everything that I don't do, she does a heck of a lot.
Speaking of smart people, right?
Oh, well, my throughput increased 5x when she came to work with me. She brought a systems approach, a process approach, and a discipline that she brought from her experience with IBM. Abigail, I apologize for talking about you as if you're not here.
You flatter me.
As long as I'm saying good things and true things, I think I can get away with it. Now, I came out of IVF programs. I ran a hospital department with 90 employees. That was somewhat systematized, but it had its mom and pop shop aspects of it as well. I work in a firm now with 16 employees. Then Abigail came to us with the discipline of having come from the consulting side and the engineering side and the methodologies at a place like IBM, which I have profound respect. And that's the core of our team. And the team is built out from it. So I like to think, and again, there are fabulous people looking at this problem, incredible people who want to solve this problem. I do think we're kind of multilingual in a way, that having been an investment professional for 20 years and working on term sheets and valuations and structuring transactions, more importantly, knowing how the IVF world works on a macro level and knowing how it works on a micro level, knowing who's doing the good basic work, how to grow them, and who we're going to sell it to at the end. That's kind of the approach we want to be able to tackle this challenge from a business standpoint, from a problem-solving standpoint, and from a patient care standpoint, from as high a level as we possibly could. So you set me up well, and I hope I answered your question.
You did, and I'm hesitant to say it this way, but did you feel that the marketplace was fertile to start this process 3 years ago in assessing the opportunity, and now it's ready because it would otherwise not have been fertile to do this scaling?
It's a good question, and I try to avoid, I tried then and I try now to avoid answering that big question.
Fair enough.
The question I answer is, for each thing that I want to fund, each thing that we want, each problem we want to solve is a node on that big map that I want to make sure that there's someone who we're going to have at hello. One of the biggest problems that we saw was we store frozen eggs and embryos in a very antiquated way. It's using agricultural technology. It's manual. handwriting paper labels, which was fine when we had a few dozen eggs and embryos that we were freezing in a milk tank.
Wow.
Now that we're up to millions, it has to be fixed. So we had two major laboratory failures in 2019 that resulted in tens of millions of dollars of liability, and more importantly,
Loss of
people
eggs, right?
losing eggs and embryos that were their future families.
Yeah.
So that should be a never event. So while I couldn't answer with certainty whether the world was ready to re-engineer IVF as a whole at once, I was pretty confident that the world was ready for a better system for managing frozen eggs and embryos.
Yeah.
We found a solution. We found the right entrepreneurs. We did the work, and we invested in that solution. Now I've got a shopping list of a couple dozen more, all of which are aimed at getting to that big picture, but each one that has a market ready for it right now. It may not be the market, it may not be the piece of the market that grows 40x in 5 years, but it's a better solution that is going to be affordable, workable. It has to be a good business that stands on its own.
Yeah.
So I think the big question you asked is the important one, but I try to answer it. And Abigail and I talk about this every day. Is this particular business going to work? Because if it's not helping anybody.
Yeah, inch by inch, right?
Exactly.
So can we whet the appetite of the group a little bit about what the fund looks like, and what they can expect to hear a little bit about? And you don't have to we're going to run out of time anyway, but just a little sort of precursor to that.
Well, it's mainly seed and early stage investing. It's in specific problems with a specific measurable outcome. We're looking for large solutions that can scale. For example, you've got I know it's a very sophisticated group. One of the examples I use is we're looking for the intuitive surgical robot for embryology. The Intuitive Surgical Company did 1.1 million procedures last year, $7 billion of revenues, a market cap of between 60 and $80 billion, depending on what the stock's doing on a given day. That's one company addressing 1 million procedures. We're addressing 25 million procedures. And that's one node that we're going to solve for. Big ask, big ambition, but again, this is engineering.
Mm-hmm.
You take a lot of the work that's been done in universities and engineering firms, as well as the work that groups like Intuitive have done, bring it into IVF. So we look for very motivated, very knowledgeable, both in science and in business, entrepreneurs. We have a standard for proof of concept. We are extremely data-driven. The vision itself is analog. The vision is a story. Our job is to break it down into very disciplined engineering and then fund it in a way that makes sense. We've done a handful of investments so far. This is our first larger scale fund that we're scaling up. We're using the same playbook. The playbook is that we want to discover things, given our proprietary vocabulary, and then pass them on to the brand name investors for Series B and Series C.
Yeah.
Markedly higher valuations.
Yeah.
We originally set off to do everything for everybody. Early stage seed, early stage incubation, later stage venture, crossover, get into the public markets. Some very smart people gave us some terrific advice. They said the best bang for the buck that you bring to this problem, to this challenge, to this big thing, you have a way of figuring out and discovering this stuff early. That's where we should be putting our efforts. And that's what we're looking at.
And mitigating the risk better than somebody who doesn't know what they're doing in that early stage box. Yeah.
That's the plan.
Super fascinating. So I'm going to ask you a question and it was largely to make people think I know what I'm talking about. And I don't. So do the xenobots have any play into any of this? And if you don't know what that is, it's okay, because I just learned that it didn't exist, but it has to do with AI and biology. And I only learned it because I listened to Lex Friedman, and he had this guy from Boston who's a famous biologist that talked about xenobots and planaries. And I mean, it just blew my mind what was going on. Does that resonate at all?
Well, Arthur, I was just made chairman of the entrepreneurship section of the AI and Fertility Global Society that was just formed.
Congratulations.
Thank you. And the only reason I say that is to mitigate the fact that I don't know what a xenobot is.
Yeah, so I didn't do that to throw you a curve.
Quite all right.
It's what this guy was talking about in biology just completely blew me away. And I'm not a scientist, I'm not a healthcare person, but it really, really made sense to me. And he's a scientist, right? So anyway, so it sounds like it might have some application. So let's say that.
Well, I will say that this is, a lot of people have said that this is the century of biology, which I believe. I teach a course periodically up at Columbia University called Entrepreneurship and Biotechnology. And one of the overriding themes of the course is that our mathematical and data handling capability has caught up to the complexity of biology. Biology is a Russian nesting doll with a million levels.
Yeah.
No matter how
Nice
deep
description.
you go,
Yeah.
no matter how deep you go, it gets more and more complex.
Yeah.
And using microscopes and measurements and human eyes and calculations, we could do tremendous work. And we've done. Like the work that we did in the 19th and 20th centuries is just awe-inspiring. But we haven't been able to engineer it to scale until our ability to data handle and to rely on our machine colleagues to do artificial intelligence.
Yeah.
So that being the case, and I tell my students, I say there's no more exciting place, no more exciting playground in the economy than the biology-based economy right now.
I would totally buy that.
Yeah, that where biology meets technology. And we're trying to, our goal is to bring that to the little world of reproductive medicine, just to engineer the hell out of it to the point where anyone that needs the outcome gets it.
Yeah, I love it.
Circle.
So we have to run. Marco, thank you for connecting with us and getting this moving. Marco's out there, you guys. You can't see or hear him. And he's the nexus of our connectivity to David and Abigail and this whole project. So super excited to be involved. This has been really, really interesting. I'm so appreciative, and I'm looking forward to getting knee deep into the details of the fund and how people can participate. And we'll make sure that everybody gets in touch and vice versa. And the recording, like I said, will be posted on the website, and the YouTube channel, and you can have the file, of course. And really, really appreciate you sharing all this with us. It's just fascinating.
Well, thank you for having us. We really appreciate it.
Yeah,
Thank
and
you.
You're very welcome. And worthy. There's a lot of endeavors that are undertaken just to make money, and this has a lot more to it, clearly. So super appreciate it. As I always say, thank you everybody for being here with us today and sharing with us the only thing you can't make more of, and that's your time. Till next time. Take care. Oh, wait, we have a question. Oh, yeah, just a thank you. Okay.